Let's get going.
All right.
Well, good afternoon, everyone, and good morning if you're out on the West Coast. I'd like to welcome you to this year's first ORCOR webinar called Paying Participants in Alzheimer's Disease Research, Current Practices and Future Opportunities. I'm the chair for the ORCOR Steering Committee, and I'm really delighted today that my colleague, Emily Largent, who's in the Department of Medical Ethics and Health Policy at UPenn, is going to be kicking off this and leading this webinar. She's the co-leader for the UPenn ADRC for the ORCOR, and her research addresses ethical and regulatory oversight issues in human subjects research, including questions of participant payment. Emily, pass the baton to you. Thank you.
Thank you so much, Sophia. I'm really excited to be hosting this particular webinar. And I will just say, to offer some background, why payment, why now? And I would say that payments to research participants have really long been a subject of debate, but the topic I would say is enjoying renewed interest. There's been a resurgence of this. And I think it's for a variety of reasons that will definitely come out in the comments we have from today's speakers. But people are really seeking right now, I think, to have a deeper understanding of ethical considerations like, are we fairly compensating participants for their time and their effort in research? They're interested in the practical effects of payment. Does it improve representativeness in our samples? Does it help with recruitment and retention, as well as implementation? Just how do we think about the nuts and bolts of the timing or the form of payment and the effects that that might have on individuals? And so the goal for today is to have two panelists who have really great empirical evidence for us, and I think also can make some very nice conceptual points to talk about payment generally. And I think a lot of the lessons will be very relevant to people who are in ADRCs and thinking about these issues in their day-to-day work. I'd like to, before I hand it over to the speakers, just highlight two resources for ADRCs. First, at the fall meeting in 2020, there was a presentation on ethical considerations associated with financial compensation to participants that talked about a lot of the key terms and concepts that come up in payment: coercion, undue influence, unjust influence. I think those will come up again today, but if you're looking for a primer, you can go to the NACC website and find the talk there. Additionally, there are guidelines currently in development on remuneration of research participants, and I think those will be available in May on the NACC website. So I just have a link here and I'm flagging that should be announced soon, and that will offer some pretty extensive points thinking about all the elements I've discussed, right? The regulatory aspects, the ethical considerations, the practical implementation, and will hopefully be a great resource for the community. So I don't want to take time away from the two speakers we have. I'm happy to introduce Andrea Denny, who's from the Knight ADRC, and then my colleague at Penn, Scott Halpern, who's done a huge amount of empirical research on the effects of payment. I think we'll have two really great presentations. We are going to ask that people put their questions into the Q&A box, and I will moderate the chat at the end just so it doesn't get unwieldy. And with that, I'm going to turn it over to you, Andrea.
Great, thank you. Let me get my screen shared. Okay, it's so nice to be here today. This is a topic that is of huge interest to me, and I hope, I'm guessing, to all of you that are here today. So I'm just going to talk a little bit about what we've done at the Knight ADRC to explore the impact of payment on recruitment. And thank you to the ORCOR Steering Committee and to NACC for inviting me. So just to give an outline, really I'm going to talk about the findings from two sort of studies we did, both survey in nature. One, I surveyed all of you, or all of you that were my colleagues at the time in the outreach, recruitment, and engagement course in 2020. There's more of us now. I think there were 31 centers then maybe, and there's 37 now. And also some results of a survey that was more of a community sample survey we did to learn more about this. So why does studying payment matter? As Emily already kind of indicated, there's a national priority, right, to increase recruitment and retention, and particularly of more diverse individuals into all of our Alzheimer's disease research. And, with this emphasis on recruitment and knowing we are underrepresented in some groups, we have to figure out what can we do to be better, And one of the things that might be part of that is remuneration. And as Emily alluded to, the National Alzheimer's Coordinating Center is drafting some guidelines on payment, but I think it'll be really helpful to have this discussion today. And payment for Alzheimer's disease research participation is not standardized, and it really varies across our Alzheimer's disease research centers. Yet we know participation is burdensome. So, what are we doing about that? And payment may be, we're trying to learn, a way to increase recruitment and retention in our research generally, and particularly of underrepresented individuals. And for some of us, we think maybe ethically, it's even a matter of justice, to compensate and pay people. But as Emily alluded to, this may raise ethical issues such as worries about potential undue influence, or reduction in altruistic motivations that we like to think people come to research for. And sometimes there's confusion with us, sometimes there's confusion with our IRBs, and a real, lack of knowing what might be undue influence or what might reduce altruistic motivations. So to be clear, I like the idea of remuneration for people. We had an issue in 2019. All of your centers may or may not. We have a recruitment committee that meets once a month, where the OR core meets with our colleagues in the clinical core and that sometimes the admin core and others, to see if we're meeting our goals, right? If we're meeting the goals of getting people into our longitudinal cohorts. And at that meeting, it was brought up that in one of our studies, our adult children studies, that collaterals, or that study partners were canceling much more than usual. And so we had a big discussion on what can we do, and know that this cohort is slightly younger than our older cohort. So maybe it's, adult children having to miss work, or the participants themselves having to miss work. And what could we do? And so as a group, we discussed and we thought, providing remuneration, we should see if that would make a difference. And then we're like, well, we can't. So I should give it as background. In our, at the Knight Alzheimer's Disease Research Center, which is at Washington University in St. Louis, for our clinical assessments and our cognitive assessments that we require of people year after year, our current practice is that we do not remunerate people for that time. There's remuneration for other things like lumbar punctures and imaging, but not for that. So that's the baseline that we're coming from, that we were not doing this. So we're like, well, we can't really pay study partners without paying the participants, right? Probably. And so, we made this recommendation to John Morris, who's our director, who many of you may know. And he was like, well, where are we going to get the money? And two, more importantly, how are we going to know if that works or doesn't work? And I'm like, I don't know, I'm trying to think of ways we might figure it out. And he's like, well, what are your colleagues doing at the other OR course? So that's why we came up with this idea to survey you all, many of you, about what your practices were and how you measure them. And so we did this survey in January 2020, and then we did a follow-up to try to capture some of the people we hadn't captured in December of that year. It was a short survey, just a short 7-question survey, and 17 of 31 centers responded. And so one of the questions that we wanted to know was, do you provide monetary compensation, again, to these longitudinal participants? We were really looking at cohorts of people that come back year after year. And we found that 41% that responded did not provide remuneration. 2 of them did plan to change practice. 2 of 7 who did not currently pay did do other things, right? They did a lunch voucher, they did a parking pass. I recall seeing that people really love the parking pass. I don't know what city it was in, but that can be a really valuable resource, I think, in some of the, especially bigger cities. And 1 site did pay, but only underrepresented individuals. But there was a real variation of amounts between centers. And that includes variation in what might be seen as reimbursement of things like parking and lunching, or compensation, and what types of procedures or visits. And for the clinical assessment, which was what I was particularly interested in, there was a range of those that did pay for $20 per visit up to $80 per visit, and then higher numbers really for centers with procedures like imaging and spinal fluid collection and things like that. And then we also asked about what had brought me to the question to begin with. Do you provide monetary compensation to study partners? And this was a very small amount. Only 2 of the 17 or 12% provided study partners remuneration. And one of those provided $40 remuneration for in-person accompaniment. And this is interesting. I'd love to hear a conversation about it, but not for people that participated over the phone or virtually, because anyway. And then one of the 2 only did so when the study partner was from a underrepresented group, sorry, and that was just $25 per visit. Some did provide other things, again, like meals or parking passes. And then of note for maybe today's discussion was, do you evaluate the impact on recruitment or retention? And what we found was of the respondent, centers did not have a formal outcome measurement for how remuneration impacts recruitment or retention. And because I work in the ORCOR, that's what I really am focusing on. Responses indicated a conviction, like I have, by researchers that it would or does help. Some reported that participants indicate more anecdotally or qualitatively, maybe researching, that they appreciate the payment, or that they were advised to do this by a community advisory board, or even that their IRB recommended it. And some indicated, I think fairly, that it's done out of respect for their participants. We don't need to evaluate, we respect our participants, so we're going to remunerate them. But one center also noted, and I think this is probably true, that there are variable reactions. Some participants, even when you offer them payment, they decline it, right? And we wanted to know if people's policy or centers' policies had changed over time. And it turns out that most centers had not changed policies, though some did indicate that they, from time to time, maybe in different grant cycles, they revisited the topic of whether or not to remunerate. And that some, as I mentioned, that we're not currently paying, we're considering. And at least one of our colleagues said that their IRB was very resistant, and did not want them, had almost told them they could not give the payment. So now I'm going to skip or move on from that survey, which is, of course, of our own centers and many of us here, to looking at a study that we did, and it was led by my colleague Matt Gobble, who I think is probably on this webinar. So, he may be able to answer questions that I can't, but we wanted to learn from a more community survey what the effects of remuneration might mean for people's willingness to participate. So the key questions that we wanted to ask with this survey was, does an offer of remuneration increase people's willingness to participate? Does it reduce their perceived burden of participation? But does it also, this thing that people have been writing about and interested in, does it influence perceived altruistic value of participation? And does it influence perceived risks? Are we clouding what people perceive as risks by offering payment? And we wanted to look at this generally, and also to see if there were differences in the answers depending on the group. Some of the groups were trying to get more involved in research. Self-reported Black or African American participants, Hispanic or white participant or respondents, and also lower income. So we gave the survey to something that I will from here on out just call NORC, but just in case you're interested, it's the Nonpartisan and Objective Research Organization affiliated with the University of Chicago survey. But the people were not all in Chicago, okay? And we did large oversamples of Black and Hispanic respondents. And respondents were asked about their willingness to participate in a longitudinal cohort study of Alzheimer's disease research. So we weren't looking into some of the biomarker kind of specifics. We were really wanting to learn about people in these longitudinal kind of time-intensive clinical assessment and cognitive assessment situations. And respondents were then assigned They all have the same kind of research example, which I'll show you in a minute, but into various remuneration, $0, $50, or $100. And you can see here, just to take a look at the numbers, I won't talk through them, but you can see the different arms and the different numbers of individuals responding to the survey. So here's an example. I mean, here's the vignette. We tried hard. It's kind of hard, you know, to capture something that is general enough, but represented enough of what you think, how people might interpret this cognitive assessment type long-term research cohort. So we asked, you know, we said we're trying to study to better understand Alzheimer's disease, and we tried to lay out what participation might involve, a realistic amount of time. And we even put in that you need someone, of course, but also that we expect people maybe even for 10 years to come back, because we wanted them to really understand this is kind of a big commitment, right, to research. And then we randomly assigned to those three, you know, no payment for travel and time, $50 or $100. And then to tease out some of these questions that we've had, we asked questions that tried to understand with whether or not this compensation remuneration would affect willingness. You know, would you be willing to participate? Burden, would participation take too much time? And then a couple of different ways of trying to get at risk. Would participation risk harmful study information being disclosed or learning bad news about one's health? And then also to see if it affected altruism. And so these were the findings, and the paper is in press. I don't know if you noticed that on the first slide, so you will be able to read more if you're interested. But we found, interestingly, I thought, that the offer of 50 or 100 both increased willingness to participate, but there wasn't a difference between those two amounts. And that, to me, it was very surprising that not only was it the same effect for white, Black, or Hispanic respondents, but low income respondents. I might have thought more money might be more enticing if you were low income. And the offer of 50 or 100 reduced perceived burden for all groups except for our Black respondents. It did not have an effect one way or the other on their perceived burden. But the offer, maybe reassuringly for some of us, 50 or 100 did not seem to influence perceived risks or altruistic value of participation. So I tell you all these things to kind of lay the groundwork for what we're thinking in next steps. You know, the survey suggests there's little to no distinction, I guess, in the way we've been thinking about it, or maybe it was the way I worded the question, but between reimbursement versus compensation versus time versus incentivizing people. You know, I'd like to revisit and get all the centers, you know, feedback so that we can be a little more comprehensive. And we learned, not surprisingly perhaps, but what is compensated and the amounts of compensation are quite variable by our center. So we are not standardized at this period of time. I think, as Emily alluded to, that having some established standards or guidelines from our NACC or, you know, from the NIH, so NIA might be really helpful just to guide us, you know. And that NORC survey suggests that compensation indeed may increase the willingness to participate. And, you know, preliminarily, it leads us to believe that that could be done without a negative impact on altruism or perceived risks. But we really have a need to empirically evaluate the impact of payment on recruitment and retention. I like to think it's just enough because it's the right thing to do, but I think Dr. Morris is right. You know, we really should be scientists, right, in our recruitment and retention. And, you know, my colleagues, well, with my input, but Jessica Mazurski and Matt Gobble, both who are on, I mean, we're looking into having really a trial to understand what these impacts are. So with that, maybe I think the questions maybe at the end, I'm not sure, Emily, but.
Yeah, let's go ahead and hold the questions for the end, but I would encourage people to put anything that's come up so far into the Q&A, and we'll look at that later. And Andrea, I think you've beautifully set up Scott and the data that he'll be sharing with us. So with that, I will hand it over to you, Scott. Thank you.
Great. Well, thanks. It's a pleasure to be with you all today. And I agree. I think what you'll hear from me is highly complementary to what Andrea just presented. I'll start with the caveat that some of the methods that we've used are different, and that actually provides some of the complementarity that I alluded to. I'll also mention that our work has not to date been among persons with Alzheimer's or related dementias or their family caregivers. I do have some experience in the dementia space, being the director of one of the 4 NIA-funded Roybal centers in dementia, and then I'm also part of the steering committee of the Impact Collaboratory. But I'm not a dementia expert by any means, and I think there's definite need for further empirical work, as Andre mentioned, in that particular space. But I think there are some sort of general principles that we can allude or extrapolate from other populations, and I'll sort of present some of those data. So I think the problems with low recruitment rates are not in any way, shape, or form foreign to this audience. So I'm just going to go through this really quickly. Those problems include insufficient power to answer the primary research question, problems of selective enrollment, meaning that the people who enroll are not representative of the people to whom the results of the research would be applied. Prolonged recruitment has been shown to be the biggest #1 driver of the cost of clinical trials. And this actually has like substantive ethical implications in the sense that in a world of fixed dollars for research, the more each trial costs, the fewer questions we can answer. And so from a sort of social good model of justice, there's tremendous value in reducing the cost of each trial through augmenting the pace of accrual. And apart from incentives, there really hasn't been a lot of evidence as to other ways to augment accrual. This is an outdated systematic review, but there have been more recent ones that have reached the same conclusion. Incentives vary. They vary across funding agencies and their proposed guidance. PCORI, for example, requires that you pay patients. Well, they don't require it, but if you actually want your grant funded by PCORI, it's required because they believe so strongly in it. Other centers have very different sponsors have very different guidance on this issue. There's variability across IRBs reviewing the same multi-center protocol. This is less of a problem in the modern era where we often have central or single IRBs of record for multi-center trials. But to the extent that multiple IRBs are still reviewing the same protocol, it raises some real questions if they're reaching different conclusions, since they're all essentially governed by the same Office of Human Research Protections. And then there are even differences across studies within the same institution. We actually had a pretty, I'll say humorous, but I can think of other adjectives too, anecdote of this at Penn, where an exact same incentive for a prostate cancer trial was deemed inappropriate by our IRB, even though the same incentive for a breast cancer trial was deemed fine. So those are some sort of observational or descriptive problems of the status quo. Here are what I think people are mostly concerned about when they talk about ethical concerns with payment. The first, Andre alluded to, actually Andre alluded to both of them. So I'll just unpack them a bit. So the first is that payment may be an undue inducement, by which I mean that in the face of money, people may not think as clearly about the risks of participation as they might if money wasn't on the table. That is not to say that people, that if people do something with payment that they would not do for free, that constitutes an undue inducement, that may be a rational trade-off. By contrast, what it really means is that in the face of money, people aren't thinking as clearly about risks, and that threatens the autonomy of consent. The second concern is that payment may be an unjust inducement, which is the idea that that a given amount of money may be preferentially motivating for those who have less of it to begin with. I will say that there are many ethicists who have countered this argument on conceptual grounds, levying arguments that even if that were true, that would not actually be a justice problem, because we would be raising all boats, so to speak. That said, I think it's a sufficiently prominent concern on many people's in many people's heads that it is at least worthy of empirical evaluation, regardless of whether you sort of agree or disagree with it on conceptual grounds. So the first study that I was involved with, and actually it's the first study I'm really aware of to have empirically evaluated this question, did it in the context of persons with hypertension, and randomly assigned persons with hypertension to indicate their willingness to participate, similar to what Andrea was referring to, across nine different trials that varied in two different ways. The first way that trials varied is the payment offered, $100, $1,000, or $2,000. So different magnitudes, but three levels, similar to what Andrea presented. And we varied the risk of 10%, 20%, or 30% of people would experience side effects such as vomiting if they took the medicines. That creates sort of a 3x3 or 9 different scenarios that people indicated their willingness to participate in, and we assessed it across that. We randomly assigned the order in which people saw those scenarios to eliminate ordering effects. If you think about sort of like conceptually what undue inducement would look like from a statistical standpoint, you might imagine that in a vacuum, that there's some inverse relationship between the amount of risk of a trial and the proportion of people who would participate. In low-risk studies, you'd imagine that more people would participate, in high-risk studies, fewer. And maybe this is what the curve looks like if we don't offer money. And maybe this is what the curve looks like if we do offer money. Now, this is what we would call statistically a main effect of payment. At any given risk, more people are likely to participate, but the slope of the curve is the same. That's not what we're concerned about when we say we're concerned about undue inducement. Instead, we're concerned about this, that there's a blunted sensitivity to risk as indicated by a flattening of the curve, such that at any given risk level, not only are more people willing to participate in the face of money, but the incremental decrement in people's willingness to participate is degraded by offers of larger and larger payments. So it's a statistical interaction between risk and payment on willingness to participate that reflects the concerning nature of undue inducement. So that's conceptually what it would look like. Is that what we found? No. In fact, we found that all three curves were almost perfectly parallel to each other. We did find, as you can see, an effect of larger incentives in augmenting accrual, but the parallel nature of the curves counters any notion that there was undue inducement going on in this particular study. Correspondingly, for unjust inducement, again, taking a step back to a conceptual model of this, let's imagine that among high-income people, there's a curve that looks like this. The more money they're offered, the more willing to participate they are. Low-income people might look like either of these lines. And again, I'm just arbitrarily sort of dichotomizing income here for purposes of clearly presenting the concept, but of course it exists truly on a continuum. But maybe low-income people are more likely to participate at any given payment offer. Maybe they're less likely to participate at any given payment offer. But if you see parallel slopes of their sensitivity to payment, again, that's not undue, or in this case, unjust inducement. Unjust inducement if you think it's a problem, would look like this, where any given amount of payment above the baseline is preferentially influential among poor people. And again, that's not what we found either. Just drawing a complementarity to Andrea's presentation, here we see that actually wealthier people at baseline under $100 payment were more likely to participate than lower income people were. And that here among wealthier people, that there was a distinction between $1,000 and $2,000, but among lower income people, there was not a significant preferential effect of going from $1,000 to $2,000, even though both were superior to $100, which I think, again, is consistent with Andrea reported. So this is all sort of conceptual hypothetical work, right? It's presenting people with hypothetical scenarios and soliciting their revealed responses to those scenarios. But that's not quite the same as actually studying how incentives would work in the real world when applied to real trials. And so that's what we sought to do in the RETAIN study. The RETAIN study was actually 2 separate randomized trials evaluating whether incentives actually connoted undue or unjust inducements in those 2 trials. The data from each trial were analyzed independently. There was a single data safety monitoring board that had oversight over both. And then there was an ethics advisory board as well for the study. This is the protocol paper that was published. I'm just going to go through a sort of a consort schematic that applies to both of the individual trials in the RETAIN study. So we started by assessing patients for their eligibility to participate in one or the other parent trial. Those who are ineligible for the parent trial were excluded off the bat. And then among those who are eligible, we randomly assigned them without consent for this stage of the assignment to either no incentive, a low incentive, or a high incentive. We then got some baseline measures, including their demographic characteristics. We then proceeded to describe the parent trial to those participants, including their allocated incentive level. And then we evaluated their decision to enroll in the parent trial and then assess some secondary outcomes that I'll get to in a bit as well. And that decision to enroll in the parent trial is the main outcome of the randomized trials of the RETAIN study testing the effects of incentives. I will say that at the end, for purposes of this exploration, we wound up debriefing people, explained what we had done on the back end, and wound up giving everyone the maximal incentive so that we didn't actually rub up against ethical concerns in the nature of the research that we were actually doing here, whereby we would have been paying similar people different amounts for a similar task. And that could have raised justice considerations. So we did ultimately equalize the payments for purposes of this to make it more like what would happen in the real world. So this is the main paper that came out toward the end of 2021. The first trial that I mentioned was part of RETAIN, what happened to be a trial of smoking cessation interventions among persons with depression. And the second was a gamification intervention designed to augment ambulation among inpatients, both inpatients with cancer and those admitted to general hospitalist services. And basically what we found is in the smoking cessation trial, incentives dramatically influenced rates of participation. In fact, going from, in that case, going from $0 to a $500 incentive, which was the large incentive, doubled the participation rate. And then the $200 incentive, which was the middle incentive, was somewhat in between. In the ambulation trial, there's actually no effective incentives at all. So it would be wrong to conclude that incentives are always going to augment accrual. I think there are some distinctions that maybe we can get to in the discussion session about like why incentives worked in the smoking cessation trial, but not in the ambulation trial. I do have some ideas there. But what's important, I think, for this discussion is that in both trials, incentives did not meet our criteria for either undue inducement or unjust inducement. And in fact, you're seeing statistically significant results. And that's because these analyses were designed to rule out the possibility that incentives were acting as undue or unjust inducements, such that statistically significant p-values are consistent with an interpretation that indeed our analyses do rule out those potentially feared ethical consequences, not that they're ruled in. The last thing I just want to mention briefly, I suspect many of you are aware of this National Academy's report regarding the importance of improving representation and diversity in clinical trials. This and other things led to the American Heart Association having recently funded 5 centers across the country with center level grants to explore these issues. We were privileged to be the recipient of one of these 5 grants, and through that funding have established what we call the Better Center, or Behavioral Economics to Transform Trial Enrollment Representativeness. And through this work, we're testing a variety of different techniques, including but not limited to incentives, primarily targeted toward augmenting diversity of participation in real clinical trials. This article was actually out just last week, where we argued, we attempted to delineate why it matters that we improve the diversity of clinical trial participation. Most of the dialogue to date has been around the third of these features, that greater diversity in the participant sample will augment biomedical knowledge creation. We think that's possible. But actually not the most important or perhaps even most likely consequence of augmenting diversity. And actually, even if biomedical knowledge were not augmented by augmented diversity of trials, there are still dramatic, very important reasons to prioritize it, both on principles of trust building and fairness promotion. And then some empirical data going back to the Retain trial, and this is the data from the smoking cessation study specifically, where the incentives did exert an impact. You can see that when in the arm where people did not get money, white patients participated at almost twice the rate as Black patients did. And that gap vanished entirely with $200 or $500, suggesting that incentives may not only augment the pace of accrual, but may augment the diversity of accrual. I will leave you with these conclusions that I think basically more work is needed for sure. We don't have as robust an evidence base as we might like here, but I think the evidence base is now sufficiently robust as to shift the burden of proof away from those who are in the business of defending the propriety of incentives, like Andrea and I, and toward those who wish to deny or challenge or limit the use of incentives. Thanks very much.
Thank you so much to both of you. I think those were really excellent presentations and hopefully addressed a lot of the thoughts and concerns that have come up for people who are considering these issues at their own ADRC. I would encourage anybody who's here and has questions to go ahead and put those into the Q&A function, and I'm happy to moderate the chat. But while we wait for some things to come in, I was going to take moderator's privilege and just ask a few. So Scott, I'm going to send the first one to you, which is notably, you didn't mention coercion. And when we talk about payment to research participants, I think we well know that oftentimes people are worried, they sort of run these two ideas together. They talk about, well, we can't have undue influence and we can't have coercion. So can you say a little bit about why you didn't mention coercion?
Sure. So I think I'll answer that in 2 ways, Emily. One is at a conceptual level, and I know you think similarly because we've talked about this, so coercion by definition confers a threat of harm if the desired behavior is not adopted. So just as a pure definitional matter, payments cannot be coercive. That's not to say that they can't be problematic. But I think that the reason we don't use the term coercion is because, I mean, if you just look up the term in Webster's or Merriam or Oxford or whatever, like payment just absolutely can't be coercive, and just by the nature of the definition of that word. But it can be an undue inducement. It can do the things that I think most people are thinking about when they think about coercion. It's like getting people to do things that they wouldn't be doing if they weren't thinking more clearly. And that is just more appropriately called undue inducement. The second way I'll answer the question is that I didn't provide you all the data from the retained trial. We actually did use a scale of perceived coerciveness. We collected that in both the smoking cessation study and the ambulation study. And actually, in both cases, the ratings of perceived coerciveness were identical across arms, and actually were quite low. Now, I will say I have some concerns about the value of that particular scale, but it's the best one out there. And I think it's, additional reassuring evidence that incentives weren't doing things that we don't want them to do.
Great, thank you. I think that's really helpful for people. I always like to hear that, payment is not coercive. So I'm glad that you added that for us. And I guess both of you, I think, have talked about the importance in your presentations of measuring sort of the effects of payment on recruitment and retention. And Andrea, you mentioned specifically that ORCORs weren't tracking this, but of course, that is an animating goal of ORCORs, is to recruit, retain, and to demonstrate that we're recruiting and retaining participants. So how have you been thinking about measuring the success of payments within your ORCOR? And Scott, I'd welcome you to add on at the end if you have any thoughts about how we might measure that, kind of some group problem solving.
Well, interesting you ask, and I might even ask them to come off mute, either Jessica or Matt, because I was kind of stymied on how to measure. I mean, I thought of some cancellation rate changes, some kind of low-hanging fruit maybe, or something like that. But so retention was slightly easier, but I thought for figuring out how it influences recruitment, it was really tricky. So that's why I did turn to some colleagues that are more, I guess, scientific minded than I am, and how we might measure that. So would either Jessica or Matt, because they really are right now putting together a study to learn about this.
Thanks, Andre. And also, I just want to say thank you, Scott and Emily, for this. So I mean, to your point, we also find it challenging to think about how to measure this and how also you can isolate the impact of payment. We cannot perform a kind of experimental psychology, perfectly controlled randomized experiment. So, and I think, as Andre said, we also think it's important to distinguish recruitment from retention, right? We have an existing cohort of people who are not representative and for whom payment may or may not be an important reason for staying in the study. So a couple of just things I'll note is we've realized it's important before we start trying to intervene or in any way to actually measure among those who are already in our cohort what the impact of the burden of the study is currently. So first of all, getting some baseline measures from people before you even introduce payment is one thing we're thinking about for how we might measure the impact of payment on retention of our existing participants. And we're thinking of piloting, though, when we think about recruitment of new or more diverse individuals, we have outreach events that Andre leads. We're thinking about randomizing the mention of payment or not, at those events. And at this point, actually just looking for some feasibility data. Scott, you mentioned being able to not consent people for randomizing them into a different arms of a study with different payment levels. So, measuring the impact also involves working with our IRB, getting permission to implement an intervention without consent, which meets definitions of deception. So I guess what I would say is it's not a simple process, but we're thinking about it in a stepwise approach. And, at this point, frankly, we'd love other ideas. Matt, I don't know if you have anything you want to add, but just actually trying to implement some assessments early on.
And I should just to add, if it wasn't clear, we would not differently compensate or remunerate people regardless of what was said or not said during like a community event.
Yeah, I mean, I think that sounds great. I would say that through our work at the Better Center, I think one of the reasons we were selected by the AHA for this work is that, we've shown that we can figure out the logistics here and work with IRBs, and we've demonstrated that embedded trials testing either incentive-based or non-incentive-based recruitment strategies are sorely needed and meet the federal standards of minimal risk and practicability and others that must be met in order to allow waivers from informed consent. And that the debriefing process that I mentioned that occurs on the back end in the retained trial, or occurred on the back end in the retained trial, is part and parcel of that process as well. That sort of enhances the alignment with the OHRP rules about when such waivers can and ought to be granted. So anyway, I just say that as an offer. If anyone's interested in collaborating, we're really motivated to see this work move forward across disease areas. Even though we're specifically funded in cardiovascular disease. The other thing I'll just mention is, I wonder if there are lessons to be learned from the pediatric literature here as far as Alzheimer's disease is concerned. And by that, I mean, like in persons with dementia, where it ultimately the decision may fall to the family caregiver. That's of course what happens in pediatric trials as well, for different reasons, of course. But I'm thinking back, my younger of two daughters was the first person in the Philadelphia region to be randomized in the phase 2 trial of the Moderna vaccine for COVID. And there's no chance in hell we would have participated had we not received a fairly healthy incentive. Not because we didn't want to do it. In fact, my daughter, fortunately, it was my altruistic, empathic daughter, not my self-centered daughter that was being randomized here. But she would have done it either way, but I was the one who had to drive her back and forth to the clinic 20 times, and it just wasn't going to happen otherwise. So, I'll just mention that N of 1 experience.
Great. Thank you to all of you. We do have quite a few questions now coming in through the chat. So one of them, we have several actually now about study partners. And Scott, I think that your point is really nice, how, oftentimes in Alzheimer's disease research, right, we require that you bring somebody to clinic with you who serves as an informant. We know that these folks offer emotional support. They help with logistics. They monitor for adverse events between visits, depending on the nature of the study. So how do we think about offering incentives for study partners, distinct from the individual? We could pay both, we could pay one. And I've heard a few comments now too about compensating study partners differently depending on whether they're from an underrepresented group or not. So if people have reactions to that, building off of what you just said, Scott, that would be great.
I like the idea, just personally, of compensating study partners. They're really part of the research. We can't do the research without them, and they're giving their time, right? So I think it's the right thing to do. And I also think to me, it might incentivize, I don't want to ask my kid to do this, but I feel better because I'm like, well, you're going to be compensated for your time a little bit for this, so I would think it even makes it easier for the research participants to feel comfortable asking someone in their family or close friend or whatever to help. So I like it in that way. I don't know what people think about their time on the phone or, or virtually versus in person. I can see arguments both ways. So I'd be curious what people think.
I will say I've done some qualitative research with study partners who have indicated that it would be helpful to have payment to increase participation. But I think here, as elsewhere in these discussions, payment obviously is just one lever that we can pull to make participation more appealing to individuals. And I think it's really important to think about the range of ways that we can make studies more amenable to participation, whether that is nights and weekends or, improving how we outreach, thinking about offering benefits to people, all of that. I'm also going to put a paper in the chat for the meeting that discusses study partners and how we might think about paying them using that pediatric model for some guidance that Scott mentioned. I think that's a great plan. Another thing that's coming up across a few of these questions is the idea of how we think about the mode of payment. So folks have mentioned there are different ways we can do this through cash, various, debit cards, checks. People have pointed out that these can have maybe different appeal to different individuals. And so that ties in with a question I wanted to highlight as well, that is really, what do we think about talking with advisory board or community members as we design offers of payment?
I can take a first stab at that one. We've wrestled with this a lot, and in fact, we had a group of our staff members who've been very frustrated with the likely inequities associated with CLIN cards and other forms of their debit cards that our university typically requires / forcibly suggests that we use. And so we've really pushed back on this. At the end of the day, cash is the way to go. It's the most equitable. It's the most flexible. It does have some challenges of assuring it gets to the right place, of course. But it's the least burdensome for people. And if our goal is to augment both the pace of accrual and particularly the equity of accrual or accrual opportunity, it really ought to be cold hard cash.
Can I just add, Emily, that we've also, just to iterate, sort of echo what Scott just said, even a check is a problem for people who are unbanked, which we have an issue with here, raising questions of equity. And I also just wanted to note, I was surprised by the finding of just paying those who are under-resourced or from underrepresented groups. And I guess I would want to say that I think that in itself could be stigmatizing, and I would advocate for paying everyone, regardless of their socioeconomic status or what group they're from. I just wanted to add that.
Fully agree.
Another thing when we talk about the method of payment is the amount, and we think about this, several people are mentioning the tax implications. Does anyone have any thoughts on how requiring a social security number or making people receive a 1099 might affect participation?
Yeah, so we have some experience there too. We actually engaged a diverse group of stakeholders about how we can best surmount this for a ongoing trial that we're doing, where we're paying older adults to quit smoking, and the incentives that we're using for smoking cessation are well in excess of the $600 limit at which you need a W-2 filled out. It's a problem, right? Like it is a little bit of a barrier. People don't love filling out that form, but there are ways that our stakeholders have guided us about messaging it, that like to just become clean. Like, this is a federal requirement that we get this information. We think you deserve this money. Here's everything we're doing to protect the confidentiality of the information you give us. And unfortunately, it's either, if you don't fill out this form, we can't give you the money that you actually deserve. And with that kind of language, we really haven't seen it erect any major problem. I can't say for 100% certainty that there aren't like a couple people on the margin who, for whom that proves to be a deal breaker. But certainly incentives plus a requirement for filling out that form is better than no incentive at all.
And, beyond the tax issue, it's been raised in other discussions that people that get certain, maybe Social Security, SSI or things like that might potentially lose benefits. And what I feel about that is, these are people that, barring people that Scott was discussing, but assuming they're not necessarily with cognitive impairment, we just need to be educated so that we can be sure that we let them know what the potential issues are, and then they can choose or not choose. But I do worry about it just being buried in a like 10-page consent and not having, whether it's recruiters or, you know, your intake screeners, knowing enough about it to really pull it out. If, you know, I think it's probably a small percentage of people, but if they really might lose some very meaningful benefits.
And not necessarily that small when we think about, you know, dual eligibles who might be on Medicare and Medicaid, or older adults who are really dependent on disability income. So yeah, I think that's a very real challenge and something we're thinking about. So I have about 3 minutes left that I get to ask you questions, and I have 2 more that I'd like to ask based on what's coming through in the Q&A. One of these is, Scott, could you just briefly mention why you thought incentives work in the smoking cessation worked in one trial, but not in the ambulation trial?
Yeah, I think it's a point of diminishing marginal returns. It turned out that baseline participation in the ambulation trial was already quite high, so there just wasn't a lot of opportunity for incentives to exert their impact. It was upwards of 50% at baseline, whereas in the smoking cessation trial, absent incentives, baseline participation was more like in the 15 to 20% range. So there's much more opportunity to see an effect. The other thing is that the ambulation trial was so low risk that people were just making a decision like, sure, why not? Or no, I just don't like research in general. And those aren't, that last group of people aren't people who are going to be moved by incentives. Right. So, whereas the smoking cessation trial was demonstrably higher risk. And so there was just more opportunity for incentives to work there. So I guess I would say if you're doing a trial that's literally like of almost no risk whatsoever, that may not be the trial in which incentives are worth the money. This does tie back into the question about like, should sponsors be giving you a bigger budget to use incentives?
You're anticipating my last question, so this is a great segue. It's how do we pay for this? Well,
so I would say that it's not crystal clear that using incentives should increase the budget, because if you're choosing the use of incentives properly, you're going to augment the pace of accrual, and thereby the money you put toward paying people to participate, you don't need as much money for recruiters, or at least as much time of recruiters, whether that's, research coordinators or however you're doing your recruitment, it all has costs. So I'm not absolutely convinced that budgets need to be bigger to accommodate incentives. That said, any thoughtful investigator recognizes that NIH R01 budgets, for example, have been flat for 40-something years. And so not that the overall budget's been flat, but like the amount of money you get for a typical R01 has been flat. And that's a little bit out of pace with inflation rates. So, there are other reasons to increase budgets, but I don't think this is one of them.
Okay. So it sounds like you think that we can maybe shift where we're putting our budget dollars with some of the benefits of payment, but not necessarily needing to increase the overall budget, but not saying we shouldn't increase budgets for research, just not for incentives. And then Andrea, do you have any last thoughts on this from the ADRC perspective?
No, I mean, on the last question, I will say, really, our participants are the gold that we do all the research on. So I feel like, I hope Scott's right that it wouldn't be more costly, but even if it were, I just think maybe it's that fairness or justice issue that we still should look for ways, but maybe based on some of the findings that for Scott's research, I think, was it 1,000 to 2,000 wasn't a big differentiation, or in ours, like 50 to 100, so maybe you can get a lot of the same benefits if they really are at trying to figure out that sweet spot, right?
So I think that's a great thought to end on, and I'll hand things back over to Sophia, right? But our participants are the gold, and we need to think about how we can improve recruitment and also treat them fairly and think about all these issues as we navigate studies. Sophia?